All right. Thank you, everyone, for having me. I'll be presenting a case on tumor invasion as an indication for CTO PCI when the LIMA has to go. I have no disclosures. So this is a 63-year-old gentleman with a past medical history of hypertension, hyperlipidemia, and coronary artery disease. Had a mid-LAD stent put in back in 2003, which was a Cypher stent. Those are, for those who are not familiar with them, are bulkier stents. They're closed cell, first-generation drug-eluting stents. This was known to be occluded, and he subsequently had a LIMA to his LAD. And he presented to a partner hospital with cough and chest discomfort. Initial workup, including an echo, showed an LV function that was approximately 55% and normal. And his chest CT had an interesting finding with a large tumor that was engulfing his LIMA. Surgeons at the referring institution thought that it had the characteristics of a malignant lesion. And so he was sent to us for CTO PCI of his mid-LAD with an attempt to allow the surgeons to potentially get rid of that tumor without compromising blood flow to his heart and causing an MI, and potentially also coiling his LIMA. Our initial images here, you can appreciate dual injections with a guide in the LIMA and a guide in the left main, and a long segment of occlusion in the mid-LAD, in-stent occlusion, and the LIMA itself was patent with good anastomosis. Also, the left circ had a chronically occluded large OM. It was a co-dominant system, and the ramus had also moderate to severe disease in the proximal segment. His right coronary artery, I don't have a better view, but this one was a co-dominant RCA with moderate disease in the proximal segment. And so, to put it all together, this was a 63-year-old gentleman with a mid-LAD in-stent CTO, moderate to severe ramus disease, and left circ with minor disease and an occluded OM, and an RCA that is co-dominant or non-dominant with moderate disease. His LIMA was patent, ZF was normal. We calculated a JCTO score of about 4 based on the findings I just showed, and a progress CTO score of 1. Our primary plan was to approach this mid-LAD CTO via left radial and right common femoral access with Antegrade wire escalation with or without Stingray as a primary approach, and a retrograde via the LIMA as a secondary approach, with an indication being the tumor engulfing the LIMA. And so we proceeded with Antegrade wire escalation. We got a microcatheter, in this case was a Turnpike LP, and a workhorse wire into the proximal occlusion cap, and tried different wires here. However, unfortunately, we were not able to pass the wire into the heavily calcified proximal cap, and the wire kept going into the subintimal plane. At one point, we were able to get the wire to advance into the stent, at least that's what we thought, but then in the middle picture, in the iliocranial view, you can appreciate that the tip of the wire was heading the wrong way. And so we pulled our base of operations back and decided to move to a retrograde approach through the LIMA at that point. Got a Turnpike LP down and over a workhorse wire, and then used wire escalation again using several wires, including a Fielder XT, a Pilot 200, and we're able to successfully get through the distal cap. However, despite being able to get that far, we were not able to penetrate through into the proximal occlusion cap, and every time we used different penetrating wires, including in this case a Hornet 14 and an Astato 20, our equipment would back up, and the microcatheter would fall back into the distal LAD. And so at this point, we decided to give the Antegrade approach another attempt, and we went with the Pilot 200 again, Fielder XT, penetrating wires like a Hornet, and we used the Miracle Brothers 6 and 12 to catch tissue and try to gain momentum, and we were able to get some, but eventually ended up in a subintimal plane. However, finally an Astato 20 penetrated the distal cap, and a Pilot 200 was threaded into the distal LAD. Microcatheter was advanced, and we switched to a wiggle wire and started our case. So at this point, we started with 2.0 balloon to dilate the entire stented occlusion segment, and followed that with a laser atherectomy 0.9 catheter at 80/80 several runs. That allowed us to pass an IVUS catheter, which showed a distal reference vessel diameter of 3.5 and a proximal of about 4.5 millimeters, and a long occlusion of about 70 millimeters with significant disease in the proximal LAD back to the ostium. And so we treated the entire area with a 3.0 angiosculpt to finalize the preparation of the lesion, and we ended up anticipating that the patient might need surgery in the near future on that tumor if all goes well. We ended up deploying 4 Cobra stents, bare metal stents with approved for short depth. We used a 3.0/30 distally and 2 3.5/30s in the mid, and a 4.0/12 in the prox. Post-dilated those and got a great result with a significant improvement in his flow there. And now, finally, to address the LIMA, we were able to deploy 2 Azure Terumo hydrocoils in the LIMA successfully, and we confirmed that it occluded with angiography. So we sent the patient back to the referring physician with the plan to continue DAPT for a month, reassess with another CT to see if the tumor is headed one way or another, and decide on the next step. Fortunately enough, we heard back from I don't have the image, but we heard back from the referring physician that the tumor actually started shrinking and had the necrotic center. So the surgeons decided to watchfully wait here before they do further and see where this is headed. So in conclusion, careful procedural planning and utilization of the hybrid algorithm will increase your chances of success in CTO-PCI. CTO-PCI indications are not limited to symptom relief, LV function recovery, or life-threatening arrhythmias, and LIMA coiling can be feasible and is safe once successful LAD CTO-PCI is performed. Thank you.
I think you guys just invented the field of interventional cardio-oncology. Congratulations.
Thank you.
Well, apparently this is going to be a seminar on coiling.
Yeah.
Nice job. That was a great case. Couple questions. Initially, you were trying to get through the proximal cap, and you were able to puncture through, it looked like, with an Astato and then a Hornet as well, I think. Mm-hmm. But could not get anything going through the proximal cap. Mm-hmm. Then you tried to go retrograde, and then you went back proximal. What did you do differently the next time that allowed you to get through the proximal cap?
So we, the next time, we actually used a Miracle 6 and a Miracle 12 to catch tissue. That enabled us, I think what was happening the first time is that our microcatheter was hitting the thick struts of the stent, and was abruptly stopping there, and we were not able to advance things. So what we did is we pulled our base of operations back and tried again with Miracle 6 and Miracle 12, which allowed us to catch tissue and direct the microcatheter in a different angle.
Okay.
And then the Hornet and the Astado were able to penetrate
Good.
through the proximal cap.
Yeah.
Yeah, I mean, I think, and did you guys think about cross-boss at all with this? I know it was hard for me to tell exactly where the stent was, but cross-boss tends to work pretty well if you have good support. That's a major caveat, of course.
Right.
If you have good Antegrade support in terms of in-stent occlusions and being able to burrow through those.
Yeah, it doesn't do great getting through, real fibrotic caps, but
Yeah.
once you've dealt with the cap
Exactly.
issue, cross-boss oftentimes will go true to true if you're inside the stent. And so it does sometimes get caught on stent struts as you're going, but sometimes a knuckle kind of redirect can
Yeah.
help. But it's a great strategy for trying to keep a true to true. The last question I have is, what was the decision making for using bare metal stents?
Let's talk about that.
So, good question. I know we very rarely use them. That I have to say, and we know that newer generation drug-eluting stents are now getting pretty close to that mark of 1 month or less for DAPT. At that time, I think the discussion with the primary care referring physician, he actually requested that we do that for the patient. So we went with the Cobra for that reason.
Yeah, there's an interventional cardio-oncology group, and there's a few of us throughout the U.S., and one of them have interest in this, and we've had a couple sessions at Sky, where there should be another one this year in Atlanta in May. Essentially, we've gone away from bare metals and just used drug-eluting in stop DAPT at a month. Cesar Iliesco, he's an interventionalist at MD Anderson. He takes it a step further and has done a lot of work in this area, and will sometimes take patients back in OCT. And if it looks like you will never know 100%, but if it looks like the majority of the stent is at least covered or has some kind of endothelium or so forth, he'll even stop it sooner with good results. And again, this is not randomized, but that's kind of the way we lean towards cancer patients.
Yeah, I would agree. I think in 2019 there is zero indication for a bare metal stent. Zero. And I think we now have the data with Synergy, soon to have data with Xience on short DAPT. The senior trial showed that it was fairly safe with 1 month of DAPT in an elderly higher risk population to stop dual antiplatelet therapy at 1 month. My big concern with this in this particular case too is now you've put in 100 millimeters of bare metal stent in the LAD in an area of restenosis, and so almost certainly this gentleman is going to need a third layer of stent in his LAD, and so I think you have now given up on his IMA, and he needs those LAD stents to stay open. I just think that there is no role for bare metal stents. And if a referring provider asks you to put in a bare metal stent, you need to educate them on why that is a poor option. If a general cardiologist ever asked me to do a bare metal stent, I simply will not do it.
So, and I agree with you. So I was at Heart House early this week, and we had an almost 20-minute argument about this. So there's a lot of people we're gradually moving away, almost totally away from using bare metal stents. But for the boards, which is where you, and this is how I emphasize this, for the boards right now, per the latest DAPT guidelines, it would be bare metal stent if you had to do only for 4 weeks. But in your case, the patient, eventually the tumor went away or necrosed away. But for the boards, stick with bare metal for the 4 weeks, okay?
It's unfortunate the boards remain 5 years behind clinical practice, and that's going to continue, unfortunately. But yeah, I fully agree. LAD, you've quoted the LIMA. DES is don't ever let a primary care doctor tell you what type of stent to use, my advice, because the last primary care doctor I've spoken to, I've never spoken to a primary care doctor that knew anything about stents. So do what you think is right for the patient. You're coiling in LIMA, 100 miles of stent in the LAD, do the right thing, and stop DAPT after 30 days. If you need to OCT it, I think that's fantastic. Or if you feel the need to do that, that's great. But you have a lot of data supporting DESs here.
That was a really good case, really good job.
Yeah.
Thank you.
Thank you. Great
Thanks.
job. Did you have a comment? Did you?
No, it was made very.
Okay.
Now, hopefully, as we move towards a living document guideline, the guidelines will get updated as the evidence keeps coming out. But for now, we're still working on that. But because the guidelines are still a bit behind the evidence, right now, it will be bare metal 4 weeks. Okay.